Hello and welcome to today's webinar. We're not quite ready to begin. We'll get started here in a minute or two. I'm Richard Nongard, the Executive Director of Peachtree Professional Education, and I want to thank you for participating in this webinar on post-traumatic stress disorder, evidence-based treatment, and the DSM-5. Over here in the chat box, it's over here to the side, you can actually type in your name and say who you are and where you're from. That would be awesome. It's always good to know who's here. Of course, some of you are participating in this webinar not as a real-time event, but are actually participating by viewing our video archive. Everybody who signs up for any of our webinars has access to the 24/7 Video on Demand Center. And if you have any questions, and it's not during the real-time event when the chat box is over here, you can actually go to our forum at changeworkforum.com. And you can type in any questions there. It's a great community of mental health professionals, and we actually meet on Facebook to make it easy for people to find and easy for people to use. I'm looking forward to getting started. Dave Park is going to be joining me here in a few minutes. We have a number of great webinars coming up. Dave and I did another webinar series on taking a life, counseling people who have killed other people. Every month at fastceus.com, we offer professional ethics as a real-time webinar. And if you check our schedule on fastceus.com, you'll find all kinds of great opportunities for continuing education. Again, we'll give people about a minute and we'll get started. Over here to the side is the chat box. Introduce yourself and say hello. Great to have you here today. Well, hello and welcome to today's webinar. I'm Richard Nongard with fastceus.com, the Executive Director of Peachtree Professional Education, and this is part one of our two-part webinar on post-traumatic stress disorder, evidence-based treatment, and some of the changes in the DSM-5. I'm really looking forward to the material, and I'm looking forward to Dave Park sharing some insights and some ideas for treatment with those individuals who are on our caseload with PTSD. Now, most of you who are participating in the webinar know who I am. You've participated in other webinars with me. I'm Richard Nongard. I'm a licensed marriage and family therapist, a certified clinical hypnotherapist, and I've been doing psychotherapy for about 25 years. And I've worked with a number of children, adolescents, adults with PTSD from a variety of different causative events and experiences in life. And in today's webinar, I'm looking forward to creating a practical event where Dave and I can actually share some ideas so that when the webinar is over, you'll actually have the resources to affect your clients in a very positive way. Again, my background really is entirely different than Dave's background. He's got a fantastic background for sharing information about post-traumatic stress disorder. He won't shy away from some of the controversial areas, and I'm really looking forward to his participation. So, Dave, if you would, introduce yourself.
Thanks. I'm David Park. I am a BCC board certified coach with the Center for Credentialing and Education. I specialize in strategic intervention, hypnosis, and neurolinguistic programming. I'm a former Army Ranger. I spent about 8 years in and out of Iraq and Afghanistan for about 8 months a year. So that's the background that I'm bringing to this webinar.
Certainly, and I am looking forward to his insights, particularly as a new generation of warriors returns back to the homeland. And this is becoming a very significant issue within the VA, within the military itself, and certainly within our communities. And one of the chief changes in the DSM-5 is really going to expand the availability of the PTSD diagnosis. And this is certainly an issue for politicians from an economic perspective as they try to provide services, but certainly for the resources of the VA, of the military itself, and of the communities where these veterans live. Again, today's workshop is not going to focus solely on the needs of the military community. We're going to be talking about post-traumatic stress disorder that could have its emergence really in any type of scenario or situation that meets the criteria. But Dave's insight is going to be, I think, very timely and very important as we really enter, I think now probably about our 11th year or 12th year of being a nation at war with returning veterans each and every year. So I'm looking forward to that. Just a couple of housekeeping things. First of all, off to the side is the chat box, and you can type in your name and say who you are, where you're from. It's always great to know who's here. And you can ask me or Dave a question at any time by simply typing in the chat box. We'll be happy to answer any questions you have. If you're watching this after hours in our 24/7 video on demand center and you have a question, you can still ask us a question. We'll be happy to answer. And you can visit our forum at changeworkforum.com. I'd love it if everyone, even if you don't have a question, would zip on over there and actually join the forum. It's where we meet on Facebook. It's a group of professionals, psychologists, social workers, marriage and family therapists, all networking to share information and help us be more effective at the work in the work that we do. And so please sign in. By the way, at the end of the workshop, there is a link below, and that'll take you to a 1-minute course evaluation. And when you complete that, it'll automatically generate a CEU certificate to your email box. So it really is a pretty simple process. And again, I want to welcome you to today's webinar. Before we actually get into the material related to treatment methods and strategies for impacting post-traumatic stress disorder, I want to talk about some of the significant changes in the DSM-5. The reason why is simple. The criteria have been changed to some extent. What this is going to do is actually create a broader base for whom the diagnosis of post-traumatic stress disorder is available. One of the significant changes is that criteria C in the DSM-4 has actually been broken down into two parts, criteria C and D. And by the way, if you're wondering where can I look at the new diagnostic criteria for the DSM-5, you can always go to dsm5.org and look at the American Psychiatric Association's webpage. But I'm going to cover those things right here, right now, before we actually get to the material, because I think one of the most important aspects of providing the correct intervention with clients is actually providing a correct diagnosis. Post-traumatic stress disorder, to some extent, over the past couple of decades, has become almost a psychofad. It appears that at various times in our profession we latch onto one diagnosis as sort of the catch-all for clients who are having difficulty. For a while it was bipolar disorder, for a while it was post-traumatic stress disorder, for a while it seemed like every kid had oppositional defiant disorder, and it just seems that at various times diagnoses are popularized and overextended so that any client who experienced stress or difficulty in life receives a diagnosis of post-traumatic stress disorder. If our client says that they have difficulties or they have problems as a result of a previous experience in life, we've tended to simply diagnose that as post-traumatic stress disorder. One of the things that I really appreciate about the DSM is that it has always been very thorough, not in all areas, but particularly as it deals with post-traumatic stress disorder. And there are very specific criteria that must be met for a person to receive a diagnosis of post-traumatic stress disorder. And again, this is very important because when we diagnose somebody without an awareness of the diagnostic criteria, we tend to overdiagnose, and that tends to overtreat, both from a medication and even from the intensity of psychotherapy perspective. Also, if we look at the other related conditions that a person may experience related to disaster syndrome or acute stress disorder or other diagnoses that are available to us, we can we can truly meet our clients' needs by being accurate. I've always said the most effective intervention really is accurate assessment. Well, the DSM-5 makes really some significant changes from the DSM-4 in post-traumatic stress disorder. So before we actually get into the 3 hours of material that we're going to spend looking at evidence-based treatment and the methods of working with these folks, I want to take a few minutes to familiarize everyone with the criteria from the DSM-5. First of all, these criteria apply to either adults, adolescents, or children older than 6. There is a preschool subtype for children younger than age 6 that is in the DSM-5. This is the first significant change, essentially a preschool PTSD diagnosis. Now, this is a 3-hour webinar on post-traumatic stress disorder, and I do not and am not an expert in treating the preschool child. And Dave isn't either. We work primarily with adults and adolescents, and because this is an area that is not our expertise, it's a very significant and important change for those who do work with preschool age children. But that's not our area of work. And so because we're limited in time, this workshop is not going to be discussing the criteria for the preschool PTSD and the interventions with the younger than age 6 child who's diagnosed with the subtype of preschool post-traumatic stress disorder. But if you do work with that very unique population with the very young child, certainly there are some significant changes that you should be aware of and the availability of a preschool subtype for children age 6 and younger. Here are the criteria that must be met, and there are 4 diagnostic groupings. The first is A. There has to be an exposure to an actual or threatened A, death, B, serious injury, C, sexual violation, and at least one or more of the following ways. So there has to be A, exposure to actual or threatened death, serious injury, or sexual violation. And it has to be experienced in at least one of these 4 following ways. 1, directly witnessed, directly experiencing the traumatic event. Okay? Directly experiencing the traumatic event. Criteria 2, witnessing in person the traumatic events as they occurred to others. Now, let me give an example from September 11th, 2001. We all watched on TV the horror of the World Trade Center building in New York City. And most of us watched on television as people leapt from the upper floors of the World Trade Center because it was really their only escape, and we knew that they were dying. In fact, there was a famous picture. It's called Falling Man, and I think it actually won a Pulitzer Journalism Award. And it was just a devastating day, and many of us watched that on television. And even though we may have had very intense emotional responses to it, the diagnosis of post-traumatic stress disorder isn't made because we saw something on television. It can only be made, and you live in New York City, it can only be made when we are actually witnessing in person the traumatic events as they occur to others. There is no diagnosis of vicarious post-traumatic stress disorder. 3, learning that the traumatic event occurred to close family members or a close friend. Cases of actual or threatened death must be violent or accidental, not simply a result of illness, which can also be traumatic for a family member. Or 4, experiencing repeated or extreme exposure to aversive details of the traumatic event. First responders collecting human remains, police officers reportedly exposed to details of child abuse. This does not apply to exposure through electronic media, television, movies, pictures, unless the exposure is work-related. And again, the DSM-5 committee has been very careful to make sure that an expanded diagnosis of vicarious PTSD, because we saw these events unfold on live TV or something like that, are not used as the diagnostic criteria for post-traumatic stress disorder. When a person has experienced the actual event in one or more of those ways, then we can look at criteria B. The presence of one or more of the following intrusive symptoms associated with the traumatic event. The key word there is intrusive symptoms. Dave and I are going to spend a lot of time talking about how do we stop the intrusion of these thoughts that that really torment those with post-traumatic stress disorder. So there has to be the presence of one or more of the following intrusive symptoms beginning after the traumatic event has occurred. In other words, there are some people who had intrusive symptoms prior to events, and events may exacerbate those. The diagnostic criteria require that these are new intrusive symptoms in order for a diagnosis of PTSD to be made. Otherwise, we may be dealing with somebody with a generalized or other form of anxiety disorder. Here are those 5 intrusive symptoms. 1, spontaneous or cued recurrent, involuntary, and intrusive distressing memories of traumatic events. In children, you can note that play may occur in which themes or aspects of the traumatic event are expressed. 2, recurrent distressing dreams in which the content or affect of the dream is related to the event. And the DSM-5 gives us a note, again, for children, that there may be frightening dreams without recognizable content because we're not at that cognitive developmental stage of the subconscious mind where it would be necessarily attributed to the event. But in the adult, we're looking for dreams and affective aspects of those dreams that the dreamer, the patient, directly relates to the traumatic event that they experienced, sometimes called nighttime terrors. And 3, dissociative reactions, flashbacks, in which the individual feels or acts as if the traumatic event is recurrent. Such reactions may occur on a continuum, with the most extreme expression being a complete loss of awareness of the present surroundings, and essentially the word we use in hypnosis, a revivification of the experience. They're not simply recalling something from the past, but they're actually reliving that experience from the past. And that is on the continuum of flashbacks or dissociative reactions, the most extreme noted in the DSM-5. Number 4, intense or prolonged psychological distress at exposure to internal or external cues that either symbolize or resemble an act of a traumatic event. Now, this is, again, using hypnotic language, the concept of anchoring. We anchor our emotions and experiences in life to a variety of environmental cues. Almost everybody watching this webinar can relate to this. Have you ever been driving down the road and you're just doing whatever it is when you drive down the road, texting and putting on makeup or eating a cheeseburger, whatever it is people do when they're busy driving. And you're not even paying attention to the radio, but suddenly a song comes on, and you haven't heard the song in 5, 10, 15, or 20 years. But as soon as that song comes on the radio, instantly you are jolted out of your automatic driving behavior, and you become aware of not only the song, but an emotion associated with it, and maybe even a prior life event. Musicians write music that is designed, that's how you create a number 1 hit, to evoke emotion. So, because this is the goal of many musicians, they know they sell more when there's an emotional response. Most of us can relate to simply going about the task of the day and that song instantly changing our mood. It makes us happy, or it brings us into a state of depression, or reminds us of a prior life experience. This is really a normal experience that everybody has in life, related to certain environmental and awareness cues that are in our everyday life. It becomes diagnostic for post-traumatic stress disorder when opening a door becomes an emotional cue to revivify, flash back to a prior experience, or a loud noise, or an unexpected experience, or a news report, or the simple mundane things in life bring a person back specifically to traumatic prior events. Number 5, a marked physiological reaction to reminders of traumatic events. One of the things that we need to sort of recognize is sort of the history of the DSM-4 and DSM-5, even back to the DSM-3. And although the DSM-5 puts post-traumatic stress disorder in its own section of stress-related disorders, in the past it was included in the anxiety disorder section. Anxiety disorders, and anxiety is particularly physical, And many of our clients with post-traumatic stress disorder, they not only have emotional and cognitive awarenesses of prior events and experiences, but they have a physical response to the traumas that they've experienced before. They are somatic in their manifestation of the psychological distress that they experience. And so we're looking for, and the keyword here is marked, physiological reactions to the reminders of traumatic events. Everything ranging from shakiness to sweatiness, to palpitations, to that feeling of butterflies in the stomachs, or really any of the other physiological symptoms that we may see in the other sections of the DSM-4 related to panic or related to anxiety disorder. For many of the post-traumatic stress disorder clients that I've worked with over the years, it is these physiological responses that are actually the most stressful to them. They begin to fear then that they're having a heart attack, or they begin to fear that they're dying. They begin to feel those physiological manifestations, and that often becomes the most difficult thing for them. As psychotherapists, I think often our attention is focused on the emotional aspects, but these physiological aspects can be among the most distressing of symptoms. Now, the major change in the DSM-5 was really taking the C criteria from the DSM-4 and creating a C and D. I just covered or taking the B and C and turning it into an expanded set of criteria. And so what we have here is now criteria C, persistent avoidance of stimuli associated with the traumatic event, beginning after the traumatic event occurred, as evidenced by efforts to do one or more of the following. So what we have here is the persistent intrusion of experiences, or the client goes to extremes to avoid those persistent intrusions. And so here are two of the ways which people might make that effort. One, distressing memories, thoughts, or feelings about or closely associated with a traumatic event are avoided at all cost. For example, they never open that bedroom window again, or they never go back to that intersection again, or they refuse to watch TV ever again, or they won't talk to people ever again. Anything to avoid a distressing memory, a distressing thought, or a distressing feeling. They also avoid external reminders, people, places, conversations, activities, situations that arouse distressing memories, thoughts, or feelings about that are closely associated with the traumatic event. And then criteria D. Negative alliterations in cognitions and mood swings, and mood associated with the traumatic events, beginning or worsening after the event occurred, as evidenced by two or more of the following. And I know it's sort of subtle, but this after the event occurred is really important. There are people with anxiety, stress-related disorders, depressive features, etc., who sometimes manifest these things prior to the onset of a trauma. And for a diagnosis of PTSD to be made, there must be a unique response to the trauma discussed in criteria A, or else a different diagnosis is made. So D is negative alliterations in cognitions and mood associated with traumatic events, beginning or worsening after the event has occurred, is evidenced by two or more of the following. And there are 7 things in the DSM-5. The inability to remember an important aspect of a traumatic event. 2, persistent and exaggerated negative beliefs or expectations about oneself or the world. I'm bad. No one can be trusted. The world is completely dangerous. It could be expressed as I've lost my soul forever. My whole nervous system is permanently ruined. Often those all or nothing thoughts. 3, persistent, distorted blame of self or others about the cause or consequence of the traumatic event. Could be related to survivor's guilt to some extent here as well. 4, persistent negative emotional states. Fear, horror, anger, guilt, shame. Persistent is the key word here. Negative emotional states. I think we all have some negative emotional states at one point or another. We're looking for a persistence in them. And 5, a markedly diminished interest or participation in significant activities. For example, before the trauma, I loved bowling. Now I won't bowl. I find no joy or pleasure in it. Number 6, feelings of detachment or estrangement from others, almost an involuntary shift in perceptual position where they can no longer see or experience their life as them, but see it as an outsider and a detachment from those who are most important to them. And number 7, a persistent inability to experience positive emotions. So we have the presence of those persistent negative emotions coupled with a persistent inability to experience positive emotions, unable to have loving feelings, a sense of psychic numbing, the inability to feel happy or to smile or to feel a sense of even relief, safety, or security. And then criteria E, marked alliterations in arousal reactivity associated with the traumatic event. So when there is a cue, a remembrance, a subconscious or a conscious awareness, the alliteration is in arousal and reactivity, beginning or worsening after the traumatic event, as evidenced by at least 2 or more of the following. 1, irritable or aggressive behavior. 2, reckless or self-destructive behavior. 3, a hypervigilance. 4, an exaggerated startle response. And again, these things have to, for diagnosis to be made, have to appear after the traumatic event. For example, I don't know why, but I have a heightened startle response. If you were just to say boo, say boo.
Boo.
Right? Yeah. I tend to startle easy.
Yeah.
And so this would not be diagnostic. You would have to look for one of 2 of the other criteria because that was already present in my life prior to any difficult experience. Number 5, problems with concentration. 6, sleep disturbances, difficulty falling asleep or difficulty remaining asleep, a restless sleep, waking up too early, etc. And in the clients who I've worked with over the years, sleep disturbances seem to be among the most impairing symptoms. I've always said I function only as well during the day as I slept during the evening before. And our clients who have difficulty with sleep as a result of the intrusiveness or the alliterations of arousal and reactivity related to dreams and sleep, they experience a tremendous amount of difficulty in relation to PTSD. And then, of course, there are a couple of other things that are of time duration and rule outs that the DSM-5 gives us. Criteria F, the duration of the disturbance, criteria B, C, D, and E, is more than 1 month. In other words, if I experience a car wreck, and I actually did several years ago, I was driving down the street on my street where I lived, and a lady, I feel bad for her, she had just bought a brand new car. It was her first day. She had it for 2 hours. This tells you how long ago it was. She was trying to figure out how to work the cassette deck, and she didn't see the stop sign. Went through the stop sign, T-boned me. Both cars spun around. Hers hit a tree, and I looked and I was okay, and I ran out to get her, and she was okay, and both of our cars were totaled, and both of us were okay. And the police came and they did the accident investigation. I felt kind of bad for her. They towed off the cars, and I went home. Over the next couple of days, it was interesting. I kept having dreams. And I kept having dreams of going through that intersection, but instead of me being hit by a car, I would drive over the neighborhood kids. And my dreams were really weird. I kept dreaming that the neighborhood kids were like 2-dimensional pop-ups from the street. And it would wake me up. And this continued. And I had other symptoms related to this experience. I would be driving down the road, and I would dodge imaginary cars that weren't there. And this all went on for a week or 2, or maybe even 3, and those symptoms all disappeared. In fact, I haven't thought about them until I started talking about this, and
Did you revivify?
And I revivified, yeah, it came back to me. But what's important here is that it is normal to experience these symptoms after a traumatic event. The diagnosis can only be made when these symptoms persist for more than 1 month. And that's really important. Nobody on September 21st, 2001 in New York City, no matter where they were on September 11th, could be diagnosed with PTSD. And the reason why is because at least 30 days must elapse before a diagnosis can be made because it is normal for us to experience these things.
And there's even talk about 4 months, right? That is still
Right.
the acute stress phase for the first 4 months.
Yeah, exactly. We can break it down. The first 4 months is that acute stress phase. Then the 4 to 8 month period is that acute PTSD phase. And then 8 months or longer can be broken up and looked at really the chronic phase where the symptoms continue.
Right.
And so we do see this as a continuum.
Right.
Criteria G is the disturbance has to cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And this may sound obvious, but sometimes people just have strange responses. And if it's not causing impairment, if it's not distressing to them, if it's only distressing to us or other family members, sometimes we get irritated by the behaviors of others. That's not PTSD. That's somebody in the family not allowing a person to experience life the way they
Right.
want to experience life. It has to cause clinically significant distress or impairment, not going to work, not getting out of the house, not getting up and taking a shower during the day, not eating, not sleeping, not taking care of oneself so that they are impaired in the important areas of functioning. And then criteria H is that the disturbance is not attributed to the direct physiological effects of a substance, medication, drugs, alcohol, or another medical condition like a brain injury, a stroke, or other type of situations we have. We then have in the DSM-5 specific the ability to give specifiers. We can specify if it is with delayed expression, if the diagnostic threshold is not exceeded until at least 6 months after the event. And this is something we see. They don't immediately go into PTSD on day 31. They seem to hold it together. And maybe there's even another either conscious or subconscious activation of these symptoms, and so that the onset is literally a delayed expression. They don't emerge meeting the criteria until at least 6 months after the event. And that is a specifier we can specify. The DSM-5 also gives us the post-traumatic stress disorder in preschool children, which I will let you review at dsm5.org, rather than me covering it here, since the focus of this webinar is not on those children under age 6. Now, I think many of the ideas that we're going to talk about could actually be adapted and useful with that age group. But again, it's not our particular area of expertise. We'll be focusing on children, adolescents, adults, but not the preschool population or the preschool subtype. Then we have another subtype that is available to us in the DSM-5, and that is the post-traumatic stress disorder with prominent dissociative symptoms. These are depersonalization, derealization symptoms of dissociation. In this experience, the person meets the diagnostic criteria for PTSD. In addition to that, experiences persist or reoccurrent symptoms of either one, depersonalization, an experience of being detached from, or as if one is an outside observer of one's mental process or their body, feeling as if they're in a dream, a sense of unreality of self or body, or of time distortion and time moving slowly or quickly. Or 2, derealization, an experience of unreality of one's surroundings. The world around the person is experienced as unreal, dreamlike, distant, or distorted. Or B, the disturbance, the criteria here is, of course, this disturbance, the prominent dissociative symptoms, are not due to the results of a substance. Cannabis smoking, alcohol, benzodiazepine, sedative hypnotics, or other either prescription or non-prescription medication, or of a health condition. For those working with preschool children, note that the dissociative and preschool subtypes are not necessarily mutually exclusive. If you work with the preschool age child with essentially preschool PTSD, a dissociative and preschool PTSD subtype can actually be made simultaneously. But I think it's important to cover the changes in the DSM-5. We're going to spend the rest of the webinar looking at the specific ideas which can actually help us to minimize these symptoms and to help our clients fully recover. One of the other significant changes in the DSM-5 is that it's really reliance on measures of severity. That global assessment of functioning that we were familiar with in the DSM-4, we gave them a GAF score between 0 and 100. The DSM-5 looks at it entirely different. We've done away with the multi-axle system in the DSM-5. By the way, if you're not familiar with the DSM-5 changes, which really are significant, we offer a webinar on the changes in the DSM-5. So that's something available to you that really covers a lot more than this. But the DSM-5 has done away with the multi-axle system, an Axis 1, an Axis 2, an Axis 3, the Axis 5, the global assessment of functioning, and asks within each diagnostic category to really assess the severity of client condition. And the DSM-5 uses from the National Institute of Health the NSESSS, the National Stressful Events Survey of PTSD short scale. And you can actually find this on dsm5.org. You can go to the diagnostic criteria for post-traumatic stress disorder and click on the severity tab, and you'll actually find it. In fact, I will post a link so it's easy to find in our forum at changeworkforum.com. But what it does is it's a self-report that asks the client to measure 9 areas of the severity of their condition based on those prior criteria. And these type of tools can be really useful for the clinician to conceptualize both progress and recovery, severity of condition, and the acuity of client condition. And this is really important. In a few minutes, we're going to spend some time talking about suicide and suicide risk. And the reason why we're going to do that is really important. The epidemiological studies related to post-traumatic stress disorder indicate that of the psychiatric diagnoses in the DSM-5, those with a diagnosis of post-traumatic stress disorder are exponentially and at greater risk of suicide. So we're looking really for a couple of different things. And the research points out that there are really 4 things that we're looking for. We're looking for a duration that's chronic, more than 1 year of symptoms. So one of the first questions we would ask a question as we measure severity is, how long has this been going on for you? If it's been going on for more than 1 year, the epidemiological studies show, hey, this person is at elevated risk for suicide. The second thing we're looking for is, are they a pot smoker and alcohol user? These are the 2 drugs associated with the post-traumatic stress disorder self-medicator increasing risk for suicidal expression and suicidal action. The third thing we're looking for is a history of prior abuse. And the reason this is important, I think in the field of psychotherapy, we often still rely on Freud's idea and say, I couldn't develop today because of my prior experiences. I don't believe that we are tied today to our prior experiences. But when we have PTSD, we often have a person who had unresolved childhood PTSD that wasn't effectively treated. And because the resolution there was never dealt with following physical, sexual abuse, etc., they sort of double down on their symptoms and their inability to cope as an adult when they are re-traumatized. And so what this does is it exacerbates the situation, the intensity, severity, and coping strategies, and we see this as an issue. And then the fourth thing that we're looking for as we measure severity of condition is there significant depression coupled with the PTSD? Going beyond symptoms of anxiety, intrusive and distressing symptoms, do we see a clinical depression? And here's the interesting thing about the DSM-5, because we don't have a multi-axle system anymore, we simply can have multiple diagnoses. And we can have PTSD, a diagnosis of major depression, coupled with other psychiatric diagnoses. And when we see that major depression coupled with the post-traumatic stress disorder, we have a person who is exponentially at greater risk for suicide. Now, we're going to come back and look at suicide in a little more detail here in a few minutes. In order for us to do the assessment process, whether it's using a tool like the NIH gives us or the new criteria in the DSM-5, we have to establish rapport with the clients who are on our caseload. And and Dave, why don't you spend some time addressing the issue of rapport? Because a lot of times the PTSD client has almost closed himself off. And if we have the depersonalization and the dissociative symptoms, they don't see themselves as being a part of something. It can really be difficult to bring ourselves in rapport with those folks.
Right. And we've talked about this in other webinars. First off, sort of the gentle approach towards the client. And I know that as a therapist, you probably engage in this anyway, but there's also the allowance of the client right where they are at the time they are. One of the challenging things I think sometimes with rapport is that once we have it established, right, that really we become an authority figure and we become trusted. And if the client, for instance, maybe they're just processing some challenging feelings at the time, but they may not have a full-blown case of PTSD in the way that it's defined here. If we go ahead and tell them, once we have established rapport with them and they trust us, if we tell them that you have PTSD, or if you tell them that, I think you might have PTSD or whatever else, then we may actually be giving them the suggestion to develop PTSD. If PTSD in itself, we're not sure exactly why it happens. Right, we do know that people with the higher neuropeptide Y level are more resistant to it. It's almost like Teflon for PTSD.
And this is something that's true in the military's aware of this as they deal with special forces. And
right. They did studies. They wanted to know why people in the special operations community had a much lower incidence of PTSD, even though they were the ones who were more often than not engaged in combat. And what they found was that it was higher levels of higher levels of neuropeptide Y. In fact, they could almost determine who would make it through the selection course of almost any service, any special operations force. They could tell who would make it through by the levels of neuropeptide Y.
Who would make it through from a psychological
perspective because of the ability to handle stress. So they know that it is that sort of buffer to stress, the neuropeptide Y.
So, and this is really an important thing because while this is one of the ideas, there are many ideas as to why people develop PTSD.
Right.
And we have to recognize that we are a combination of our biological factors, our psychological factors, learnings, copings, our spiritual factors, how well we are at meeting our deepest needs, and the social resources and factors around us. And to recognize that why one person who experiences not every firefighter and police officer in New York City on September 1st developed PTSD. Not everybody in the building did who escaped, but some did go on to develop PTSD. What is the difference? And physical differences.
So there's that. So there's that physical difference, which at least it may be a buffer. Now I don't know if there's also, if the decrease, the more you go down, if somebody becomes more and more, if they become more, susceptible to getting it. Excuse me. If they become more susceptible to getting it. But the other things is it could, in a large way, be a number of cognitive distortions that go on that continue to cycle down. Now, one of my beliefs, as we look at the military, and this gets a little controversial, when we look at the suicide rate in the military right now, amongst the active duty military and veterans, we see that right now it's currently about 1 per day, which is high, obviously, which is crazy high. And there's no real rhyme or reason why the suicide rate amongst veterans is so high. Now, as a civilian, a lot of people think, well, they've been in combat, they've seen these horrible things. But the reality of the situation is 90% of them have not been in combat.
Yeah, there's an interesting, we have a journal article here piled up, and it's talking about PTSD and returning veterans, and the diagnosis of PTSD being made in, I think, 45% of the cases among those returning veterans who saw no combat.
Right. So well, that's it. In fact, there was a study, either 2010 or 2011, I can't remember which now, but I think the number was, and I could be wrong, but of 112 guardsmen that had committed suicide, half of them had never even deployed, right? So, and this sort of ties back into rapport, but the idea that PTSD itself and suicide, there are studies and ancillary studies, or studies and sort of research saying that it very well could be a social contagion, right? That it's a meme. And so when you say why are so many veterans have this PTSD? Why do so many veterans commit suicide? That if you look at all the messages that are in the media now about broken veterans, about PTSD, about the difficulties of returning home, and returning home could be difficult. You're going from one world to another and trying to integrate those two, and a lot of times it's more the
cultural integration stress,
right, that starts creating the isolation more than what happened over there. Right? Coming home can be challenging. Trying to reintegrate into your family, trying to reintegrate into society. For a lot of them,
when you leave and your kid can't talk, and then you come home and your kid is telling you to move out of his chair,
right?
All of a sudden, wow, your world is entirely different.
Well, think of a veteran who maybe does not have a college degree and goes over there, spends maybe 4 years in the military, is maybe a sergeant or staff sergeant in the Army or whatever branch service, but has leadership responsibilities, has led troops in combat, or if not led troops in combat, at least managed troops in daily activities, and then they come back and
get a job as a pizza driver.
Yeah, they can't get a job because they don't have a degree. Right. The civilian world doesn't recognize their leadership experience, so they take a step down in their own significance and their own certainty. So I think that when we're looking at...
And so then we see the problems that could have a cause other than criteria A, the direct
other than the
experience,
trauma.
And we say veteran PTSD.
We say veteran PTSD.
Right. And it's almost as if you're saying there's not really a balance in our media where we say the wounded veteran, we need to be compassionate, we need to recognize the needs of these folks, and all of that is true, but we don't say, and soldiers also return with valor, confidence, and pride.
Right. Almost every story now is, it may be a hero story, but it's a hero story from the angle of the broken veteran who's doing okay. Right? Not from somebody who just came back and readjusted and got on with their life.
Right. Yeah. We forget that psychological resilience is actually the norm, not the exception.
Right. So with the rapport and the gentle approach is a non-judgmental approach, and that goes both ways, right? Not judging the soldier as weak, but also not just jumping in and saying, look, I know you're going through a really hard time now, because that's almost feeding into what the rest of society is giving them. And what that does, that may cause a veteran, if you're dealing with veterans,
right, to
question their own resilience.
And it almost goes back to some of the criticisms of critical incident stress management. For years, people were taught, hey, if you have somebody who's experienced trauma, you need to do critical incident stress debriefing. You need to get them to talk about it. You need to get them to share it. You need to get it out on the table. And the research actually shows that that's actually contraindicated. That with many folks, this is not necessarily best. And so rapport is best developed not when I tell you what you need to be addressing in therapy, but when the client decides in therapy what is most important to them. You see, people may not present with a diagnosis of PTSD. They may come see me, I'm a marriage and family therapist, because of money trouble and they fight with their wife.
Right.
But then we may see that the presenting problem, marriage counseling, is not the actual problem, which in this case is PTSD, but allowing the client to set that agenda in therapy. But how do we do that when I may recognize, I've worked with thousands of people in therapy, and I may know, hey, look, this client has this issue. They don't see it as their issue yet, but they're going to in 3 or 4 months of therapy because that's what happens in therapy.
Right.
And so why don't I just get it out on the table now?
Well, I think that, I mean, in any of these works, the person has to come to the conclusion themselves a lot of time, right? And it doesn't matter what, I mean, isn't the role of a therapist in a way an influencer role?
Right.
Right? And in any influencer role, whether you're a therapist or a salesman or anything else, it's always far more persuasive when your client reaches the conclusion on their own.
Sure.
Right? Because if they haven't gotten to that point yet and they're unwilling to accept it, then you're going to meet resistance. And the more often you go at it, and the more resistance they put up. So if a point in time comes when they actually realize that you are right, they may not even admit it, because now they build up so much resistance, and I have identified so much with that resistance, that they won't let it go. Yeah. The flip side of that.
You sound like student of Rogers.
The flip side of that too, though, is if you do have a veteran in particular, and maybe anybody, but veterans right now, I think because it's such a hot topic,
Sure.
that if they come in and they've self-diagnosed with PTSD, and they say, I have PTSD, and I think it's okay to offer them an alternative. Well, you know what? How do you know you have PTSD?
Right.
Well, because I have this and this. And, you say, well, you're right. You may have PTSD. You may have PTSD, but this and this, it might just be this and this.
Right.
So, and really give them an option other than PTSD.
Right. Now, what are some basic strategies just for building rapport? I think that most therapists are really pretty comfortable with a lot of different types of people, different backgrounds, different experiences. But sometimes we do encounter clients who, for some reason, we either don't feel a connection to, or we may feel intimidated by their experience or other things. What are some basic strategies for building rapport? I mean, on a very simple level.
Well, I think one is to maintain your frame as the therapist, right? To as a coach, I'm never like overly helpful or overly empathetic, because that may not be what they need
I always
at that
say
time.
I'm friendly to my clients, but I'm not their friend.
Right.
I give them maybe advice and wisdom, but I'm not their mother.
Right.
And to stay in that role of they'll test us to see if we'll transgress that role and become their friend or become their enemy.
Right.
And when we, back to Carl Rogers, hear anything without raising our eyebrow, we pass the test.
Right. And and I think rapport is often misunderstood. Like rapport, a lot of people think that rapport is, I think it's multifaceted, and a lot of people think that rapport is simply this person liking me. But in the role of an influencer, rapport goes so much deeper. When I was in, I did 3 different boot camps, 3 different basic trainings. I did the Navy, the Marine Corps, the Navy, and then the Army.
And by the way, our webinar guest today has actually technically worn all 4 uniforms at one point or another.
Right.
So.
Right. So, we were not friends with our drill instructors or our drill sergeants.
Right.
We weren't their buddies. But, probably 3 or 4 months through, 3 or 4 weeks into training, if we thought they were disappointed in us, we tried harder. Now, you could say that's Stockholm Syndrome or anything else, but but isn't that deep rapport right there? Right? So, it wasn't that we were their friends, but we knew that they had our best interest at heart.
And I think that's important for my clients to know. They sit here, this is my office, this is where I see clients, and they need to know that I have their best interest at heart.
Right.
That I am their advocate, even though I'm not their friend.
Right.
Even though I'm not their mother, even though I'm not their lover, their spouse, or any other role that sometimes, occasionally, we see confusion on. Now, from a rapport building perspective, one great idea is again questioning.
Yes.
I've always, it goes back to an old story I heard about a guy who gets invited to a millionaire's house, and he wants to impress him. And so what does he do? Instead of telling him how great he is, he simply spends all night long asking the millionaire questions about him.
Yeah.
And at the end of the evening, the millionaire basically says, "Wow, you're the greatest guy ever." But he knows nothing about him.
Right.
And hires him for this, grand task or grand job. And really, here's your interview tip. When you go see the interviewer, they're going to start asking questions about you. You start asking questions about them. I see you have a dragon in your office. Have you been to Asia before? And that's going to build that rapport. Wow, somebody was finally interested in me.
Right.
And for me, it's really easy to be in that teacher role with my clients and tell them what they need to know. And I have to really pay attention to that, probably
Right.
more so than other therapists, so that I can ask them what they need and simply let them explore their own solutions from the questioning process that I guide them through. Now, let's move on and spend some time talking about some specific issues related to suicidal ideation, because I think this is a super important area to address. Now, because the PTSD diagnosed client is an exponentially greater risk for suicide, I want to make sure, even though this is not a suicide webinar, that we just cover some of the basic things that I think are indicators that we need to look for. And the first is from a demographic perspective. Who's at greatest risk for suicide? And the demographics tell us that those who are at greater risk for suicide, I ask this question, it's interesting to mental health professionals, say, who's at greatest risk for suicide? And they'll say teenagers or college-age kids. Actually, with each year of life, we increase suicide risk, which is why when we're dealing with PTSD and the Vietnam veterans, who are all 60s and 70s at this point, in the 80s, we're really looking at elevated suicide risk, especially if that depression has been present, alcohol addiction has been present, and untreated PTSD. But the older a person is, the more likely they are to attempt and succeed at suicide. Men, interestingly enough, are twice as likely to succeed at suicide than women. But women are twice as likely to attempt suicide. The reason why is men tend to choose more lethal methods. Men choose hanging and gunshots. Women choose cutting and overdosing. And gunshots and hanging are more lethal, so it results in more deaths, even though females actually have more suicide attempts. By the way, never underestimate the importance of suicide attempts, even if the attempt was not actually intended to cause death, because I'm convinced more people accidentally die trying to kill themselves than actually die because they intended to kill themselves. There are cultural and racial differences in the prevalence of suicide. Whites are at greatest risk, followed by Native American Indians, then followed by African Americans, then followed by Hispanics. And the unmarried person is more likely to both succeed and attempt suicide than the unmarried person. There is an elevation with those who self-identify as being homosexual, an elevated risk for suicide. And then, of course, we're looking for a family history of suicide or a close friend who's committed suicide. This is often not necessarily hereditary. I mean, there could be some biological aspects here. That's not the scope of this webinar. But when they've seen somebody else succeed at suicide, they actually receive the message, wow, that worked.
Right.
And so they are more likely to both attempt and succeed at suicide. A diagnosis of PTSD exponentially indicates the risk. All PTSD clients should be assessed on a regular basis for suicidal ideation. And when we're doing that, we should be asking for a couple of things. Do they have thoughts of suicide? That's one of the things we should ask. And it's not abnormal for people to think about suicide, especially if it happens to be a topic in the news. We recently had an executive who jumped from a bridge, and it became sort of a national story. People think about it. What we want to know, though, is how intrusive are those thoughts? How frequent are those thoughts? What's the quality of those thoughts? Then we want to know, do they have a plan? I think about it, I don't know how I would do it. Versus, I think about it, yeah, I have a gun, and that's how I would do it. And then coupling that plan with I call it a contingency, and maybe a better word for it, but I would implement the plan predicated on this happening. In other words, if I can't stop being depressed, then I'll do it. Mm-hmm. If I get one more letter from the IRS, then I'll do it. Mm-hmm. If my wife leaves me, then I'll do it. If they fire me from my job, then I'll do it. Mm-hmm. So is there a plan coupled with a contingency, a point where they would move to the next level of suicidal ideation? Then we're looking for a prior attempt. Does the person have a history of a prior suicide attempt? The best indicator of future behavior is past behavior. And each suicide attempt often becomes more lethal and more likely to succeed. And of course, how recent that previous suicide attempt exponentially increases the risk of another suicide attempt. And then what is there, if we have a previous suicide attempt, by the way, we have to ask the question, did they believe it would cause death? There are a lot of people who attempted suicide in the past knowing that the method wasn't particularly lethal and they might not die. Then there are people who survived in spite of the suicide attempt. In other words, this happens with a lot of adolescents. They believe that if I take 14 Tylenol mm-hmm. and 17 vitamin Bs, it's going to kill me. And so they do, and they end up in ICU, with liver damage, but they don't end up dying from it. But did they believe that it would kill them? And that's one of the things we want to assess for in the prior attempts. And then, what about motivation? Do they have a motivation to die, or do they have a motivation to live? What are their motivations and their motivation levels? And these are the type of things that we're looking for in our assessment of suicidal ideation, prior suicide attempts, to demographics and history. And we could easily spend an entire webinar focusing on suicidal ideation. On fastcuse.com, we actually have an audio course on that. And Dave and I are probably going to do a webinar on that first part of next year. And so you can look forward to that. But it is important, if you're dealing with the PTSD diagnosed client, to be aware of the indicators of suicidal ideation and the risk factors that are present, and have knowledge and training in that area, because your PTSD clients are those of all the psychiatric diagnoses we work with who are at greatest risk for taking their own life. Now, in the time that we have remaining today, and I've wanted to cover really a lot of information that I think is important in the first part of this webinar, but we're going to spend all of the rest of our time really focusing on intervention strategies and things that we can do when a client's actually in our office. We'll demonstrate some of these with you as you're participating in the webinar. Dave and I will role play some of these things as if we were a client. And the DSM-5 gives us a lot of different symptoms, manifestations, criteria that a person might deal with, ranging from the physical aspects to the cognitive aspects to the emotional aspects. And one of the most distressing things for those with a diagnosis of PTSD are really the chronic, recurrent, or ever-present mental pictures that are so distressing. When I talk to folks with PTSD, in some ways it may be reliving or revivification, but many times they're still connected to the present day world, but they're driving down the street and they're seeing these intrusive mental pictures, almost like a daydream. They're at their desk, they're simply doing their job, counting widgets or whatever it is they do, and these intrusive mental pictures come. And when we have somebody in our office who has these experiences, what can we do with them?
So depending on whether, when it's a mental image or if it's a physical sensation, a lot of times, if we address the symptom itself, instead of saying this is PTSD, we have to address the whole thing, we may be able to affect at least some sort of relief.
That's what's cool about the DSM-5 is that it really encourages us to measure on severity. So if we get symptom relief in one area, we may still have a problem,
right?
But we're better.
Right. And, and different people will experience PTSD differently, right? So there's no really one thing that says that's what it is. Some people will have the very vivid mental images. Some people will have the very intense, physical bodily sensations. So
as we talk about these interventions, this isn't do this first, second, third, fourth,
not
fifth.
at all.
because each person is going to be entirely different.
Right, and at the core of this, and we'll go into like you said, we'll go into the deeper ones, the more all inclusive ones later. But for just the symptom relief, just become very curious about how they experience it, and then see if you can change how they experience it. So one of the things that I might do is if you said you had this mental image, like so.
Yeah, let me come up with a scenario.
Sure.
I'm role playing here. I own some rural land in rural Oklahoma, and I've had nothing traumatic happen to me there. But I'm just going to role play this so that so you can sort of demonstrate the process as if I were a client. I'm going to make up a story here.
Sure.
My friend and I, we were out on my property, and the neighbor didn't fence off his bulls, and the bull, came across the field because they saw we were wearing red T-shirts, and the bull gored my friend. We both ran from the bull, and I was able to get away, and he was gored through the back and killed there on my land, and so now I'm at work. I see a red pen on the desk, and suddenly I remember those red T-shirts and the bull goring my friend and the red blood everywhere. And when I go drive my car, I see a stop sign, and there's the red T-shirts and the red blood and the bull, and so that's just my intrusive mental image.
Okay, so
I try to sleep at night.
When you see red, is it the red, or does the image of that event of your friend getting gored come back?
It's really an image, almost sometimes like I'm watching a still picture of us. Right when that bull's getting them.
Okay.
And I can see me and I can see him.
And one of the things that I'll look for when people are doing this, like they're describing an image to me, and he said it's a snapshot, so I'm going to work with a snapshot. And when you see that snapshot, and you're looking straight ahead in your field of view, where do you see that?
It's always just like right in front.
It's always right in front of you, right there. Okay, so what I want you to do, is it there with your eyes open and your eyes closed?
Yeah.
Okay.
Yeah.
Is it in color or is it black and white?
It's in color.
Okay.
I mean, it's very real. It's like I'm just taking the picture.
Okay. So what I want you to do is when it's here and when you see it, what do you feel?
I feel a lot of anxiety.
And where do you feel anxiety?
It's just kind of starts right here, and then I just feel.
Okay. And on a scale of 0 to 10, how strongly do you feel that anxiety when you see that picture?
Like an 8 or
an 8.
9.
Good. Okay. What, an 8 or 9? Excellent. Yeah. What I want you to
sometimes
do.
Sometimes a 10. I mean, sometimes I'm just like, whoa.
Okay.
I just have to like close my eyes and like make it go away.
Okay. So closing your eyes makes it go away?
Sometimes.
Okay. Good.
Well, I can't really get it to stop.
Okay. So I want you to imagine, if you can, look straight ahead and look at that picture, and I want you to imagine actually moving that picture closer and see if you increase your level of anxiety or decrease it, or see what happens.
Close my eyes?
You can keep them open or close them, however you see it best. Just move it closer.
Okay.
And does that increase, decrease, or with your anxiety, or stay the same?
It actually almost decreases it. That's not what I expected.
Okay. All right. So if we move it back to its original position, push it back to its original position.
Okay.
And now what happens with your anxiety?
I can tell I'm a little more anxious.
Okay. I want you to move it back to about here.
Okay.
And what does that do for your anxiety?
It makes it smaller.
It makes it smaller?
Yeah.
Okay, I want you to move it back to about here then.
Okay.
And what does it do now?
I still feel anxious, but it's not really it's not as anxious as I thought.
Okay, good.
It was a minute ago when I was here.
Right. So what I want you to do now is looking right here. I want you to imagine moving the picture without following it, moving the picture over to here.
Okay.
And what does that do for your anxiety?
Kind of decreases it.
Okay, good. And so
that's not what I thought would happen, though.
And so that's just a real quick. What did you think would happen?
I thought that when I got closer, I'd become more anxious, but it was almost like it came up like a poster picture, and I could see it not real.
Really?
When it was close, and then when I moved it back, maybe it's because I need glasses, but it was.
Yeah. So one of the things that we might want to do is when he tells me that if we were working, is if it comes up like a poster picture, which means that it's very two-dimensional and he can see it, I might have him actually kinesthetically reach up with his hands and rip it or wad it up and drop it in a garbage can. So these are
a lot of therapists. I mean, what you're dealing with here is changing the submodalities, the sensorial experience of my emotion.
Right.
You're having me translate this into. Well, I'm the one who brought it as the represent
right.
is the picture, and I can see the colors, etc. But when you change the submodalities, you can. The submodalities being texture, size, shape, closeness, farness.
For visual, for sound, it would be side of the head it's on, the voice it's in, the loudness.
All of these things.
Yeah, for a feeling, if they say I've got anxiety in my chest, well, what does that feel like? What shape is it? What color is it? Is it moving? What direction is it moving? All these things are things that you can kind of get in there and give them, if not resolution, symptom. You can give them symptom relief.
Now that you've guided me through that process, one of the things when you said move it over here, and of course, even though this is hypothetical, it's very real, which is really kind of strange. But I almost felt like, wow, I have control over where it goes. I never thought about that before.
Right.
And because now I see that I have control, wow, that's almost a sense of freedom, even though it still is a distressing image.
Right. And look, we don't have to say you're going to get rid of this symptom 100%. Right? There's the idea of the unresolved remnant. It's okay if it's still there, but if they have control over it. And one of the things that
therapy isn't about all or nothing. It's not about we're either completely normal or we're completely crazy.
I haven't met a completely normal person yet.
Good.
So one of the things that I always do when I'm working with submodalities, no matter whether it's the emotion, the picture, my intent. It didn't work. But my intent when I moved it closer was actually to increase his anxiety. Okay?
Which I would expect would be, that's the response I expected, maybe because it was hypothetical anxiety, but a lot of clients may feel an increase.
Right. And the reason I want to...
But I don't think it's unreasonable to see that some would interpret it differently.
Not at all. And you just have to be ready to go with that when it happens, right? The reason I want to, like my goal normally is to increase it. Now, if it goes down when he moves it closer, great, because now he's shown himself basically that he can decrease it. My goal is to always attempt to increase it, have them increase it. Before that, I have them decrease it, because people are more willing typically to increase their pain. But if you tell them to decrease it, they'll tell you they can't.
Right.
So if I have them increase the intensity of the vision, of the sound, of the feeling, increase it, so take it from an 8 to a 9 or whatever, then I say, okay, now that you know you have control of it, now take it back down to where it was.
Right.
And then they take it back down to where it was. Now I've just shown them they can turn it up and down.
Right.
And now I can turn it further down.
Right. And again, we don't have to go all the way to zero.
No.
I do a lot of pain control work.
Right.
And one of the things about pain control is if I have somebody who's in chronic pain who comes into my office and they say they're at a level 10, they can't get anything done. They become suicidal over their chronic pain. If I can get them down to an 8 in chronic pain, a level 8 of pain, that 20% reduction is the difference between,
right.
I might not like a level 8, but I can get up in the morning at a level 8.
Right.
Whereas at a level 10, I couldn't even hear myself thinking anymore.
Right.
And if I can move to a level 8, maybe in successive sessions we can move to a 6 or a 4. And even though, for example, I became interested in chronic pain because of my own arthritis. I have my foot is filled up with metal rods and the failed joint replacements. Anyone out there with arthritis can relate to this. And there's always, people say to me, well, I had foot surgery a couple of years ago. How's your foot? My answer is, well, it still sucks. But it's 2 years ago, before the foot surgery, it was at a level 10. I couldn't get up and experience joy during the day. Now I say my foot is 70% better. 30% of it, that's still a pretty high level of misery. But guess what? It doesn't impair me
Right.
at all. And we can do this not only with physical pain, but with psychological, emotional,
Right.
distressing images, thoughts, all of these. Now, that's really a fairly simple technique.
Yes.
And in part 2 of our webinar, we're going to really expand on a lot of these techniques and ideas so that you can see some other things, some more involved processes with the client. We're going to spend our time that we have remaining today and the time that we have in part 2 of this webinar looking at some evidence-based treatment protocols. And I want to just take a couple of minutes to discuss some of those. As Dave and I share with you intervention ideas and strategies, we're really going to draw from the research. I'm a firm believer in looking at really what does the research tell us is most effective to our work with clients. Edna Foa is a professor and editor of a book titled Effective Treatments for PTSD. Now, I brought edition number 1, which I think is from the year 2000, and the second edition came out in 2009, 2010, which I think has a lot of really useful information. I really do think that as a country, and even in the world of psychiatry, we're really in a post 9/11 era. I think our understanding of PTSD, 10 years plus of war, has certainly left us with many more, not only case studies, but obviously individuals who've been traumatized by the experiences they've had, our increased awareness in the relationship between childhood sexual abuse, post-traumatic stress disorder, really all has occurred within the last 10 years. So this book is actually sort of version 1. I would encourage you to pick up Edna Foa, F-O-A, her book, Effective Treatment for PTSD, the second edition that came out, I think, in the year 2010. And in her books, she talks about those treatment protocols which have demonstrated efficacy. And so as we go through the various processes of helping people make change, these are the things that we're going to share. And there are a lot of things in the book that we're not necessarily going to touch on, but and we're going to add a few things too. But I really do think it's important to look at the research, not simply tradition or the approach that we feel would be best for our client or the approach that would be best for us. And the research shows us that there are a couple of things that really are highly effective with post-traumatic stress disorder. The first on the list is cognitive behavioral therapy. The cool thing about cognitive behavioral therapy is that we can integrate CBT into other modalities of treatment. There are advances in pharmacotherapy which can actually assist some of our clients who are in an acute phase, suicidal ideation, disorganized thinking, dissociative states, to be able to move to a point of wellness where we can teach long-term strategies for change. Now, I have never seen, I can't think of a psychotropic who healed somebody and made them well, but I have seen psychotropics stabilize people and help them to avoid catastrophe and crisis so that they can move them to a point of developing wellness. One of the other outcome-based treatments that really has gained a lot of attention both from the military and elsewhere is EMDR, rapid eye movement desensitization therapy. We'll talk about EMDR. And I was very happy to see Edna Foa included both in her first and second edition an entire chapter on the efficacy of hypnotherapy as a strategy for dealing with post-traumatic stress disorder. Both Dave and I are certified clinical hypnotherapists. We do a lot of training people in clinical hypnotherapy. If you're interested in that, you can always attend one of our training sessions. But hypnotherapy is one of those great tools for helping a person to take physical control over the difficulties that they experience. EFT is another area that's been to some extent a little controversial in the field of psychotherapy. But if you go to scholar.google.com, this is a great resource for everybody. When you want to know what works, go to scholar.google.com, not just plain old Google, but instead of www.google.com, type in scholar, where the www was, scholar.google.com, and type in EFT, post-traumatic stress disorder. You can type in anything you're searching for, treatment for post-traumatic stress disorder, and it'll just give you zillions of journal articles. That's all that Scholar Google searches for, is academic publications, textbooks, and scholarly peer-reviewed journals. And if you look at efficacy of EFT at scholar.google.com, you'll see really mountains of evidence supporting its use with a wide variety of clients. And then acceptance and commitment therapy, which coupled with other forms of contextual psychology like mindfulness-based stress reduction, dialectical behavioral therapy, other third wave behavioral approaches are among the most effective for dealing with a wide variety of the symptoms that we see with post-traumatic stress disorder. You know, Dave, it seems like in every webinar we do, I always share something about mindfulness. And mindfulness is one of the core components of dialectical behavioral therapy, of the other contextual psychologies. And when we're dealing with the client with post-traumatic stress disorder, the research, back to scholar.google.com, shows that training a client in mindfulness can help us to bring a client into the present so that they can avoid revivifying and living in the past traumas that they've experienced and avoid projecting into the future. When you have a client who is new to your office, I'm assuming you do something fairly similar to me. I give every one of my clients a short MP3 that teaches them a core strategy for practicing mindfulness, and I have them practice that every day between now and my next session with them.
Yeah, I do a 2-minute mindfulness meditation with my client. I teach them how to do it, and then I assign them to do a 2-minute mindfulness meditation twice a day.
That's exactly what I'm doing
every day.
So.
Yeah, and I start them out with 2 minutes because I find that there's a higher rate of success for somebody who will sit down and do it for 2 minutes than trying to get them to do it for 10 or 15 or 30 and get frustrated.
Sure, and I don't think the value is maybe my ADD kicking in. I don't think the value is in 30 minutes of meditation or 45 minutes of meditation. I think it's internalizing and practicing the processes. And if we can do that in 2 minutes, then we can be mindful 24 hours a day.
Right.
The idea is not that this 2 minutes is valuable to me, but what I learn in the 2 minutes, I can then take with me so that when I experience these symptoms of PTSD, I can automatically, in the past, I would revivify and become enmeshed with. I can now bring myself to the present despite my past.
Right. And for those of you who don't know, you hear meditation and you think maybe it's some esoteric or new agey type of thing. Understand that, different types of meditation have been practiced for thousands of years. And there's a type of meditation called focus meditation, when that's, staring at the candle or doing whatever. And the whole idea is to suppress any thoughts and achieve this state of bliss. Now, that's not a bad way to practice meditation, but it really doesn't have lasting effects once the meditation is done. The other type of meditation, the type of meditation we're talking about, is mindfulness. And what that is it is not suppressing the thoughts, but it's allowing the thoughts to arise, noting it as thought, and not becoming enmeshed with it. And then usually we use our breath as the anchor. So when your attention is focused somewhere, so as opposed to our attention getting enmeshed in the thought, we allow the thought to be sort of this transient, like a cloud, and then we note it thought, and we just go back to focusing on our breathing.
So if I were your client, how would you teach me in that first session?
Yeah, so I would. One of the things, some people close their eyes during meditation, during mindfulness meditation. I normally
do. I even have to use the word meditation?
We don't. We can just call it a mindfulness exercise. We can call it a practice in staying present. You can reframe this any way you want for your clients. So one of the reasons I don't close my eyes, and I don't have my clients typically close their eyes, is because we tend to visualize much more with our eyes closed. Some people do like their eyes closed, and that's fine. There's no right or wrong way to do this. I'll normally find a specific point to stare at, and that becomes my second anchor. So my breath is one anchor, the point is another anchor. And as we breathe, I'll have them count, beginners, I'll have them count from 1 to 4 as they inhale, 1, 2, 3, 4. And then as they exhale, 1, 2, 3, 4. And anytime a thought comes up, now a lot of times we'll start thinking the thought. We will become active participants. But then there comes a time when we notice that we're thinking, and then we go, oh, we note it, thought, and we go back to focusing on our breathing. And a lot of times what we focus on is the area where the air enters the nose. So some people will feel it around their nostrils, some people will feel it on their lip, different places. But a lot of times we focus on our breathing, the counting, the spot, and where the air is entering.
So this is really a training process. You're teaching a person to practice really a ritual.
Yes.
That they can do each day so that they can bring their awareness when they're bothered by intrusive thoughts to something as simple as a spot on the table or a breath.
Yes, and just by noting the thought. And it's not trying to suppress the thought. It's allowing the thought just to rise and go away, because that's what thoughts do.
It seems a lot easier to simply note a thought and let it be a thought, even if it's a distressing thought, than to try to get rid of it.
Right.
One of the interesting things, thought suppression techniques, which have been popular in therapy, simply aren't effective.
Right.
Because that's not the way the mind works. In fact, there's an old Bob Newhart skit called Stop It. And when Bob has a client who's all stressed out, and for those of you who aren't old enough to watch Bob Newhart, you'll have to go to
It's on YouTube.
right?
It's on YouTube.
Type in Bob Newhart, Stop It, and Bob Newhart plays the psychiatrist, of course, and the person's really stressed, and he just goes, stop it, stop it, stop it, stop it. That doesn't work, though. Thought suppression doesn't work. What really is more effective is going with the thought.
Right. Not now. When you say going with a thought, do you mean just getting involved in the thought?
No, I mean going with it in the letting it be a thought.
Right.
The diagnosis of PTSD is made not because we have intrusive thoughts. It's important to note that. But when the intrusive thoughts cause clinically significant impairment.
Right.
And if we can teach or train a client in an activity that despite their thoughts or despite their past or despite the horribleness of the scenario can remove the clinically significant impairment in important areas of functioning, then we are on the road to recovery with the client. And this is one strategy to do it.
Well, all thoughts are intrusive, right? If I know that I'm going to be receiving a $500,000 check in the mail next week, that thought can be just as intrusive, right? That thought can be just as intrusive and just as distracting and just as, in a way, debilitating.
And what if the mail doesn't come? I better not go to work. I better stand in front of the mailbox. My wife wonders why I'm standing out in the rain, and absolutely. And the goal here is not to erase somebody's memory of bad things.
Right.
Or to keep them from being aware of the future.
Right.
But to live fully in the present despite where we've been and despite where we're going. And that is a collection of strategies that we're really going to explore in depth in part 2 of this webinar. Now, David, I want to thank you for participating. We're out of time in today's webinar. You can always send us a question at changeworkforum.com. Below us is a link, and you can complete the course evaluation or the quiz. Take you 1 minute to do that. It'll automatically, I have to snap when I say that, it'll automatically generate a CEU certificate to your email box. There are many other webinars coming up, including a workshop on changes in the DSM-5, professional ethics each and every month. Dave and I are doing a webinar on taking a life, counseling people who have killed other people, and really many other opportunities for your continuing education. So please check out our schedule at fastceus.com, and we'll see you for part 2 of our webinar on post-traumatic stress disorder, evidence-based therapies, and the DSM-5.